Hi, my name is Dr. Hussein Hadi from the Department of Pathology and Forensic Medicine, Al Mustansariya University. In this series of 3 lectures, the lymphoreticular system will be addressed from pathological point of view. Today, I will try to outline the primary and secondary lymphoid organs. In addition, I will talk about non-neoplastic conditions of lymph node in brief. Hopefully, in the coming lectures, lymphoma will be highlighted in more details for both Hodgkin's and non-Hodgkin's types. We all know that the lymphocytes are the immunologically competent cells that assist the phagocytes in defense of the body against infection and other foreign invasion. To start with, I'll try to outline the primary and secondary lymphoid organs. Herein, the structure of the lymph nodes and spleen will be considered. Subsequently, I will try to talk about certain causes of the splenomegaly as well as hyper and hyposplenism. In fact, there are two lymphoid organs, primary and secondary. The primary lymphoid organs where lymphocytes develop in the postnatal life includes bone marrow and thymus, while the secondary lymphoid organs in which specific immune responses are generated includes lymph nodes, spleen, and the lymphoid tissues of the alimentary and the respiratory tracts. The latter is the mucosal associated lymphoid tissue, includes first discrete lymphoid structures such as the appendix, Peyer's patches in the submucosa of the intestine, as well as the tonsils and the adenoids in the pharynx. The latter is referred to as Waldeyer's ring. Secondly is the lymphocytes in the submucosa of various organs. This figure illustrates both primary and secondary lymphoid organs. The primary lymphoid organs where lymphocytes develop in the postnatal life includes bone marrow and the thymus. In the bone marrow, the B cells are more prominent than the T cells. The immune markers of the B cells are mainly cluster of differentiation 19 and cluster of differentiation 20, whereas the immune markers of the T cells are mainly the cluster of differentiation 3 and cluster of differentiation 7. In the thymus, you can notice there is a dark green area for more primitive cells, whereas the lighter blue area represents the more mature cells. In the thymic medulla, the pre-T cells lost the ability to make terminal deoxynucleotide transferase (TDT) as they convert to mature T cells. These pre-T cells are also known as T lymphoblasts. On the right side of the figure, you can notice the secondary lymphoid organs, which includes the lymph nodes and the spleen. The structure of the lymph nodes can be divided into the cortex, paracortex, and medulla, and we will discuss it in more details in the coming slides. For the spleen, you can notice it contains both the red bulb and white bulb areas. The central arterioles are surrounded by a core of lymphatic tissue known as the white bulb, which has an organization similar to lymph nodes. As you can notice in the figure, there is a central area of the germinal center surrounded by mantle zone and the T cell marginal area. This diagram also shows both primary and secondary lymphoid organs. As I said, the primary lymphoid organs where lymphocytes develop in the postnatal life includes bone marrow and thymus. The secondary lymphoid organs in which specific immune responses are generated. These are the lymph nodes, spleen, and mucosal associated lymphoid tissue, such as the appendix, Pyrus patches in the submucosa of the intestine, as well as the tonsils and adenoids in the pharynx. In the coming few slides, I'll try to talk about the main structure of the lymph nodes in more details. Lymph nodes are secondary lymphoid organs that range from 2 to 20 mm in diameter and are discrete, ovoid, or bean-shaped. The lymph nodes are surrounded by a connective tissue capsule. Beneath the capsule is a slit-like space called the subcapsular sinus. It receives lymph or interstitial fluid from the afferent lymphatics, which slowly passes through the node, consequently collecting in medullary sinusoids and exits through a single afferent lymphatic in the hilum. The parenchyma of normal lymph node is divided into outer cortex and inner medulla. The paracortex, also known as the deep cortex, is the T-cell dependent region lying between primary follicles. It consists of numerous evenly dispersed small T lymphocytes with a predominance of a T helper subset. Deep to the cortex lies the medulla, having medullary sinuses and medullary cores. They contain numerous plasma cells and are one of the main sites of antibody secretion within the lymph node. The lymph drains through medullary sinuses to the hilum. So the parenchyma of normal lymph node is divided into cortex, paracortex, and medulla. The lymph node is divided into cortex, paracortex, and medulla. The outer cortex contains spherical or egg-shaped nodules of B lymphocytes which form lymphoid follicles. In other words, within the cortex are primary follicles which are composed of B lymphocytes and follicular dendritic cells. On antigen exposure, proliferation and maturation of B cells cause the primary follicle to develop into a secondary follicle, comprising a germinal center surrounded by a mantle zone of small B lymphocytes. Outside the mantle zone, some lymph node germinal center has a marginal zone, also composed of B lymphocytes. This figure illustrates the structure of a lymph node. The lymph node is surrounded by a connective tissue capsule. Beneath the capsule is a slit-like space called the subcapsular sinus. It receives lymph or interstitial fluid from the afferent lymphatics, which slowly passes through the node, consequently collecting in medullary sinusoids and exits through a single afferent lymphatic in the hilum. The parenchyma of normal lymph node is divided into outer cortex, paracortex, and inner medulla. Lymph node contains spherical or egg-shaped nodules of B lymphocytes which form lymphoid follicles, either primary or secondary. If these virgin B lymphocytes are unexposed to antigen, they compose homogeneous primary follicles. After B lymphocytes have been stimulated by antigenic challenge, primary follicles develop central area of round, pale staining germinal centers and surrounded by mantle zone, and these follicles are now referred to as secondary follicles. The intermediate area between the cortex and medulla is called the paracortex. T cells occupy the paracortex, which surrounds and underlining the primary and secondary follicles. It is the zone situated between the cortex and medulla, which contains the mobile pole of T lymphocytes, responsible for cell-mediated immune responses. The paracortex also has abundant dendritic cells. The inner area is the medulla. In the center of the lymph node, it composed of medullary cord and sinuses. The medullary cords are occupied by B and T lymphocytes, plasma cells, and macrophages. These diagrams represent different stages in lymphopoiesis of both B and T cells, as well as development of B lymphocytes. The lymphocytes arise from the hematopoietic stem cells in the bone marrow. The pluripotent hematopoietic stem cells on commitment to development give rise to two types of multipotent progenitor cells, namely common myeloid progenitor and common lymphoid progenitor. Common lymphoid progenitor gives rise to lymphocytes. Pre-B cells give rise to naive, which is also called virgin B cells. These cells characteristically express immunoglobulin antigen receptors on their surface that have not encountered antigen. Naive B cells are small resting lymphocytes present in primary lymphoid follicles, in follicular mantle zones, and in the circulation. On encountering antigen, the naive B cells undergo transformation, proliferate, and finally mature into antibody-secreting plasma cells and memory B cells. This occurs predominantly in the secondary lymphoid organs, either in the germinal center, that's mean in the follicular area, or outside the germinal center, which is in the extrafollicular area. The development in the germinal center, which is in the follicular area, the antigen-exposed naive B cells migrate into the germinal center of the lymphoid follicle, proliferate, and transform into the large follicular center cells called centroblasts. The centroblasts mature and give rise to cleaved follicular center cells, known as centrocytes. These are small lymphocytes with cleaved nuclei. These centrocytes differentiate into plasma cells, immunoglobulin G, A, and E. These cells produce in the germinal center, enter the peripheral blood, and home the bone marrow. Secondary is the memory B cell, and the other cell is the marginal zone B cells. They can also differentiate into plasma cells. The development outside the germinal center, which is in the extrafollicular area, in the early primary immune response, the naive B cells that encountered antigen may transform into B immunoblasts in the T cell zones. The B immunoblasts mature into immunoglobulin M plasma cells secreting early immunoglobulin M antibody as a primary immune response to antigen. T lymphocytes are also derived from common lymphoid progenitor, which differentiate into pre-T cells and finally mature to form either CD4 helper or CD8 cytotoxic lymphocytes. The other secondary lymphoid organ is the spleen. We all know that the blood enters the spleen through the splenic artery, which then divides into trabecular arteries which permeate the organ and give rise to central arterioles. The majority of the arterioles end in cords. The blood re-enters the circulation by passing across the endothelium of the venous sinuses. Blood then passes into the splenic vein and back into the general circulation. The cords and sinuses form the red pulp, which is 75% of the spleen and has an essential role in monitoring the integrity of red blood cells. The central arterioles are surrounded by a core of lymphatic tissue, known as white pulp, which has an organization similar to lymph nodes. The lymphocytes migrate into white pulp from the sinuses of the red pulp or from vessels that end directly into the marginal and perifollicular zones. The spleen has important and unique role in the function of the hemopoietic and immune system. So when we are talking about the function of the spleen, we should know that the spleen is the largest filter of the blood in the body, and several of its functions are derived from this. The main function of the spleen is to control of the red cell integrity. The spleen has an essential role in the quality control of red cells. Excess DNA, nuclear remnant and sideroblastic granules are removed. In addition, it has an immune function. The lymphoid tissue in the spleen is in a unique position to respond to antigens filtered from the blood and entering the white pulp. Macrophages and dendritic cells in the marginal zone initiate an immune response and then present antigen to B and T cells to start adaptive immune responses. The spleen lies under the left costal margin and it has a normal weight of 150 to 250 gram and a length of between 5 to 13 centimeter. It is normally not palpable but become palpable when the size is increased to over 14 centimeter. The spleen, like the liver, undergoes a transient period of hemopoiesis at around 3 to 7 months of fetal life, but is not a site of erythropoiesis in the normal adult. However, hemopoiesis may be re-established in both organs as extramedullary hemopoiesis. The extramedullary hemopoiesis can occur in severe anemia such as chronic hemolysis, megaloblastic anemia and thalassemia major, or myelofibrosis or malignant disorders in the bone marrow. Here are the main causes of splenomegaly, which includes leukemia, lymphomas, myeloproliferative disorders, hemolytic anemias, glandular fever, portal hypertension, as well as malaria, leishmaniasis, and schistosomiasis. There are certain terms we should be familiar with, and these are the hypersplenism and hyposplenism. The hypersplenism is a clinical syndrome that can be seen in any form of splenomegaly. It does not imply a specific causal mechanism. It is characterized by enlargement of the spleen, reduction of at least one cell line in the blood, in the presence of normal bone marrow function. In addition, there are evidence of increased release of premature cells, such as reticulocytes or immature platelets, from the bone marrow into the blood. This figure shows the platelet distribution between the circulation and spleen in normal individuals on the left side and in patients with moderate or massive splenomegaly in the right side. Normally, about 30% of the platelet mass may be located there. In addition, only approximately 5%, which accounts for 30 to 70 ml of the total red cell mass, is present in the spleen, and up to half of the total marginating neutrophil pool. As the spleen enlarges, the proportion of hemopoietic cells within the organ increases, such that up to 40% of the red cell mass and 90% of the platelets may be pooled in an enlarged spleen. The next subject is hyposplenism. Patients with functional hyposplenism have impaired immunity to blood-borne bacterial and protozoal infections and persistent thrombocytosis. Functional hyposplenism is revealed by the blood film findings of Howell-Jolly bodies as seen in the right pictures, or Pappenheimer bodies as siderotic granules on iron staining. A Howell-Jolly body is a cytopathological finding of basophilic nuclear remnants, which are clusters of DNA in circulating erythrocytes. Hyposplenism, excluding that induced by medical or surgical intervention, occurs in a wide range of conditions, such as sickle cell disease, gluten-induced enteropathy, dermatitis herpetiformis, inflammatory bowel disease such as the Crohn's disease and ulcerative colitis, essential thrombocythemia, as well as congenital abscess and in elderly. We already discussed the primary and secondary lymphoid organs. In the next part of this lecture, non-neoplastic conditions of lymph node will be addressed. Reactive lymphadenitis. Infections and non-microbial inflammatory stimuli often activate immune cells residing in lymph nodes, which act as defensive barriers. Any immune response against foreign antigen, either infectious or non-infectious inflammatory stimuli, is often associated with lymph node enlargement, which is called the lymphadenopathy. The infections that cause lymphadenitis are numerous and varied and may be acute or chronic. In most instances, the histological appearance of the nodes is entirely nonspecific. That means different etiologies are associated with similar microscopic changes. This table illustrates the causes of lymphadenopathy. The lymphadenopathy is either localized or generalized. The main causes of localized lymphadenopathy is local infection, such as pyogenic infection, viral infection, cat scratch fever. We will discuss this disease in this lecture, and even the tuberculosis can be presented as localized lymphadenopathy. The other causes are the lymphoma. We will discuss it in more details in the coming lectures, as well as the secondary carcinoma. For the generalized lymphadenopathy, the causes are either infection, such as viral infection, for example, the infectious mononucleosis. We will discuss it in the next lecture, measles, rubella, and even the hepatitis. The another infection is the bacterial infection, for example, syphilis, brucellosis, tuberculosis, and salmonella. Fungal infection can also be presented as generalized lymphadenopathy, for example, histoplasmosis, and even the protozoal infection. Non-infectious inflammatory disease is another cause, for example, sarcoidosis, rheumatoid arthritis, systemic lupus erythematosus, or other connective tissue diseases. Malignancy can be presented as a generalized lymphadenopathy, such as the leukemia, especially the chronic lymphocytic leukemia and acute lymphoblastic leukemia, as well as the lymphoma. There are other causes which can be presented as a generalized lymphadenopathy, such as the reaction to drugs and chemicals, including the hydantoins, or even the hyperthyroidism could be presented with generalized lymphadenopathy. Now I will try to consider both acute and non-specific lymphadenitis as well as granulomatous lymphadenitis. So, acute non-specific lymphadenitis. This form of lymphadenitis may be confined to a local group of nodes draining a focal infection, or be generalized as in systemic infectious and inflammatory conditions. The overlying skin is frequently red and sometimes penetration of the skin can produce draining sinuses. Grossly inflamed nodes are swollen and congested, that mean gray-red in appearance. Microscopically, there are large germinal centers containing numerous mitotic figures. When the cause is a pyogenic organism, a neutrophilic infiltrate is seen around the follicles and within the lymphoid sinuses. With severe infections, the centers of the follicles can undergo suppurative necrosis. With control of the infection, the lymph nodes can revert to their normal appearance or, if damaged by the immune response, undergo scarring. What about the chronic non-specific lymphadenitis? This condition can assume one of three patterns depending on the causative agent. These are the follicular hyperplasia, secondly is the paracortical hyperplasia, and finally is the sinus histocytosis. Follicular hyperplasia is associated with infections or inflammatory processes that activate B cells, which migrate into B cell follicles and create the follicular or germinal center reaction. The cells in the reactive follicles include the activated B cells, called follicular center cells, the scattered phagocytic macrophages containing nuclear debris, which are the tangible body macrophages, as well as follicular dendritic cells. The causes of chronic non-specific lymphadenitis include rheumatoid arthritis, toxoplasmosis, and the early stages of HIV infection. In general, we should know that the lymph nodes in a benign reactive process are more likely to enlarge quickly, are often tender on palpation during physical examination, and diminish in size after the infection. This figure is for lymphadenitis of follicular hyperplasia type. Low power view in the left image shows marked differences in the size of germinal centers with well circumscribed character. On the high power view of the germinal center, showing numerous tangible body macrophages admixed with follicular center cells. The other pattern of chronic non-specific lymphadenitis is called the paracortical hyperplasia. It is caused by immune reactions involving the T cell regions of the lymph node, which is reflected microscopically as expanded zones between the cortical follicles. Paracortical hyperplasia is encountered in viral infections such as Epstein-Barr virus, following certain vaccination, for example smallpox, and in immune reaction induced by certain drugs, especially phenytoin. This figure shows the pattern of paracortical hyperplasia. You could notice the expanded paracortex as indicated by the arrows, as well as the separation of the distance between the lymphoid follicles. The final pattern is called the sinus histocytosis. From its name, sinus histocytosis is characterized by distension and prominence of the lymphatic sinusoids owing to marked hypertrophy of the lining endothelial cells and an infiltrate of macrophages, which is the histiocytes. Sinus histocytosis is often encountered in lymph node draining cancer, may represent an immune response to the tumor or its products. Microscopically, in the pattern of the sinus histocytosis, there is marked increase in the number of macrophages in the lymph node sinuses, as you can notice in this figure. The other condition is the granulomatous lymphadenitis. In fact, there are a large number of diseases that can result in granulomatous formation in the lymph node. They include, first, various types of infection and we'll talk about it in the next slide. Secondly is the foreign body reactions. Thirdly is the immunological condition, as well as the chemical causes such as the beryllium silica, and finally reaction to malignancies. There are various types of infections that may cause granuloma in lymph node, and these are the tuberculosis, sarcoidosis, fungal infections, brucellosis, toxoplasmosis, syphilis, leprosy, cat scratch disease, mesenteric lymphadenitis, leishmaniasis, as well as bilharziasis. At the end of this lecture, I will try to talk about the cat scratch disease in brief, as most of the other causes were already discussed in the lectures of the infectious disease, especially the tuberculosis, fungal infections, syphilis, leprosy, as well as the leishmaniasis and schistosomiasis. Cat scratch disease. It is a self-limited lymphadenitis. This necrotizing inflammatory process is caused by Bartonella Hensley, a gram-negative rod. A cat scratch may introduce the organism, which induces a papule at the inoculation site. The regional lymphadenopathy may develop within 1 to 2 weeks, followed by resolution in 2 to 4 months. It is primarily a disease of childhood. 90% of the patients are younger than 18 years of age. As I said, it presents as regional lymphadenopathy, most frequently in the axilla and neck. The nodal enlargement appears approximately 2 weeks after the feline scratch, or less commonly after splinter or thorn injury. Accordingly, a raised inflammatory nodule or vesicle is sometimes visible at the site of skin injury. In most patients, the lymph node enlargement regresses over the next 2 to 4 months. Rarely, patients may develop encephalitis, osteomyelitis, or thrombocytopenia. Morphologically, sarcoid-like granulomas are formed. These then undergo central necrosis associated with the accumulation of neutrophils, forming irregular stellate necrotizing granulomas. The reactive change in the lymph node shown here in this microscopic picture is primarily necrotizing with a radiating stellate pattern. This is the end of the lecture. Thanks for your attention.